We would like to start with an overview of what to expect during the webinar. Initially, we will present a brief introduction to Parkinson's disease. Secondly, we will discuss recent research in exercise for Parkinson's disease, followed by an overview of an exercise study that was conducted at UBC. We will also discuss the Canadian Society for Exercise Physiology guidelines for adults over 65, and finally, we will identify barriers to exercise in the Parkinson's population, and we will also offer ideas on how to overcome these barriers.
So what we'd like you to take away from the webinar today can be seen in our learning objectives. You should gain a basic understanding of PD symptoms and pathophysiology. You should be able to identify some recent research regarding Parkinson's disease and exercise. You'll be able to obtain an understanding of how UBC is contributing to the body of knowledge of exercise research in PD. You should have a better understanding of the Canadian recommendations for exercise in adults over 65, and you'll learn exercise-specific barriers to Parkinson's and the ways to overcome them. So just to begin our introduction, in 1817, James Parkinson's essay on the shaking palsy outlined certain cardinal symptoms of Parkinson's disease, which include tremor and postural instability. The first chapter of his essay defined the shaking palsy as a constellation of symptoms involving involuntary tremulous motion with lessened muscular power, with a propensity to bend the trunk, the senses and intellects being uninjured. Over time, identification of motor symptoms in PD have evolved to include bradykinesia, rigidity, speech difficulties, gait, and balance disturbances, as well as akinesia, which is the loss or impairment of voluntary movement. And while we know certain key traits of Parkinson's disease, it is still largely considered idiopathic, meaning of unknown cause. If we look into why the human body displays the symptoms associated with PD, we reason that it's due to the loss of the neurotransmitters, and most notable being dopamine. Dopamine helps chemical messages pass from one nerve cell to the next. Degeneration of dopaminergic neurons is most evidently seen in a part of the brain called the substantia nigra, and more specifically in that area, the pars compacta. This lack of dopamine is what disrupts voluntary movement control, causing the characteristic symptoms of PD. Tremor and stiffness occur when the nerve cells fire and there isn't enough dopamine to transmit that neuronal message. The other major contributor of Parkinson's is Lewy bodies. Lewy bodies are abnormal accumulations of protein that develop inside the nerve cells. The Lewy bodies usually consist of misfolded proteins, and the most common protein being alpha-synuclein. When Lewy bodies affect the substantia nigra, the hallmark motor symptoms will emerge, including the resting tremor and bradykinesia. Lewy bodies also affect areas beyond the brainstem, including the cortex, which is the thinking part of the brain. And if this occurs, cognitive symptoms develop, which might mean you have difficulty with executive function. So that's planning, ordering, or multitasking, as well as difficulty with memory, apathy, anxiety, or others. So Parkinson's is the second most common neurodegenerative disorder. The prevalence of Parkinson's disease is 1 in 100 in populations over 60 years old. That means that an estimated 7 to 10 million people suffer from Parkinson's worldwide, but the number of people with Parkinson's is growing with the aging population, men being 1.5 times more likely to have Parkinson's than women. Known genetic foundations for PD are rare, causing approximately 5 to 10% of cases in the global population. Identified mutations include the LRRK2, PARK7, and synuclein alpha gene are some examples that precipitate familial Parkinson's.
Research and clinical care in Parkinson's disease have also uncovered non-motor symptoms, which are symptoms that do not affect movement, and prodromal symptoms, which are symptoms that may appear before the classic motor symptoms of PD emerge, or before a person is diagnosed with Parkinson's disease. It is important to note that the non-motor and prodromal symptoms of Parkinson's disease are individualized, and while all of the symptoms listed on this slide may be common symptoms of Parkinson's disease, not everyone with Parkinson's disease will go on to develop all of these symptoms. Some examples of non-motor symptoms are anxiety, depression, dizziness and fainting when moving from a seated or laying down position to standing, fatigue, pain, cognition changes, and sleep disturbances. Prodromal symptoms of PD can include loss of sense of smell, depression, anxiety, REM sleep behavior disorder, which is acting out dreams, and constipation. Non-motor symptoms in PD are often poorly recognized and inadequately treated. However, attention is now being focused on the recognition and quantitation of non-motor symptoms, which will hopefully help to form the basis for improved treatments. Non-motor symptoms in PD can have a greater impact on health-related quality of life than the motor symptoms of PD. A multi-center, international, cross-sectional study on 411 Parkinson's disease patients by Martinez-Martin et al. Demonstrated that non-motor symptoms of Parkinson's disease, such as mood changes and apathy, had the most negative impact on quality of life in persons living with Parkinson's disease. In this study, PD symptoms characterized as sleep disturbances, fatigue, weight changes, and unexplained pain closely followed mood changes and apathy as being the most critical symptoms to deleteriously affect the perception of health and well-being in Parkinson's disease. In the same study, Martinez-Martin et al. Also uncovered common non-motor symptoms of PD. The most common non-motor symptoms described in this study include nocturia, which is getting up throughout the night to urinate, fatigue, and dribbling saliva. Greater than half of the study population experienced these non-motor symptoms. In the early 1960s, researchers discovered that Parkinsonian symptoms appeared when brain levels of dopamine were reduced by 70 to 80%. Shortly thereafter, levodopa, a precursor to dopamine, was shown to dramatically alleviate the slowness of movement, increased muscle tone, and tremor that are typical of PD. The discovery of levodopa as a treatment for Parkinsonism is one of the most profound discoveries in medical history, as levodopa treatment enabled people with Parkinson's disease to move again after being afflicted by extreme rigidity and compromised motor function. Levodopa remains the gold standard in anti-Parkinsonian treatment, and it is used to increase dopamine concentrations in the brain. However, even though levodopa reduces many of the motor symptoms of PD, it does not influence some of the non-motor symptoms of PD, and it does not stop the progression of Parkinson's disease.
So now to provide a background in some research, we've selected a few publications that look specifically at exercise in Parkinson's. On the screen, you see a fluorescent transgenic worm, and that means the worm is glowing due to artificial introduction of DNA from another organism. The photo was taken under a microscope from the Rankin lab at UBC, and the green dots indicate neuron bundles in the worm. We just thought it was a colorful, interesting photo to start off our conversation about research. The first study examined aquatic therapy. So aquatic exercise therapy for people with PD has become a recent focus of attention, given the emerging evidence that it has potential to be both enjoyable and to have neuroprotective benefits. Aquatic therapy also has the unique advantage of being comfortable for those who have a fear of falling, enabling them to become active. So the aquatic therapy study, published in 2017, followed 21 participants, with 11 of these participants attending 2 45-minute sessions each week for 6 weeks. The study's outcome looked at gait variability, which is a loss of consistency in being able to walk in a steady and rhythmic fashion, as well as a UPDRS assessment. And the UPDRS is the current gold standard assessment tool used for characterizing Parkinson's impairments. It consists of 3 parts, with the third focusing primarily on motor symptoms. So the UPDRS score ranges from 0 being unaffected to 147 being most severely affected. And only small improvements were seen in gait variability over time, but the average UPDRS scores dropped following the aquatic therapy intervention from 17.5 to 13 in only 6 weeks, which is great. And there you can see a graph from the study. The next paper was a systematic review and meta-analysis, which investigated exercise to prevent falls in older adults with a component pertaining specifically to Parkinson's. They compared 6 different trials, and each one examined the effects of a different type of exercise in fall risk in populations with PD. So the exercises varied quite a bit. It ranged from progressive balance and lower limb strengthening exercises to Tai Chi, treadmill training, and MST, which is movement strategy training. And as you can see, there is evidence of a fall prevention effect. So the graph shown on the screen is called a forest plot, and the bold vertical line that you see here is the position where there's no difference between an intervention group and a controlled group. But the black box on each line shows the result of the study, and the diamond at the bottom is the average of the results of those studies. So anything on the left side of that bold solid line indicates that the results of this study favored exercise and that there was a decrease in fall risk seen with that respective exercise. So the next study looks at the effects of treadmill training on cognitive and motor symptoms of PD. The study had 17 participants enrolled, with the treatment group participating in 12 45-minute treadmill sessions, with 1 session per day on Monday, Wednesday, Friday for 4 consecutive weeks. And the participants trained at 1 kilometer per hour for 10 minutes, then they upped it to 1.5 kilometers per hour for 10 minutes, and they finally reached 2 kilometers per hour for that last 10 minutes. So the study outcomes were looking at both cognitive and motor assessments. Going through a cognitive assessment, they used one called the MOCA, which investigates a patient's skill in 7 domains, including executive function and memory. The MOCA is scored out of a total of 30, and in the study they saw a mild improvement of 1 score for the treatment group. The next assessment is called the trail making test, aka the TMT, and there's 2 parts, parts A and part B. So it specifically assesses selective attention, psychomotor speed, and sequencing skills, and the shorter time to complete the trail, the better. An example is shown on the screen, and if you look at test B, you can see that it moves, and what you're meant to do is go from 1A to 2B, and then if we were to continue the test, you'd want to move from 3 to C. The TMT improved by 20 and 50 seconds respectively following the intervention. A motor outcome that was tested was the 6-minute walking test, and that's selected as a measure of gait speed. So the subjects were asked to walk on a flat, hard floor at their fastest speed for 6 minutes without the use of a walking aid or other assistance, and participants were able to walk 36 meters further in 6 minutes after the treadmill training. The BDI, the Beck Depression Inventory, focuses on psychological aspects of depression, and it consists of 21 items, each rated on a 4-point scale of severity, meaning the total sum of the score is 63. And the BDI dropped nearly half, from 11 to 6 following the treadmill intervention in only 4 weeks. And the UPDRS score, which we already discussed, which ranges from 0 to 147, dropped by 3 points in the study from 40 to 37. It should be noted that more treadmill studies have indicated in order to see these results in the UPDRS, the exercise intervention needs the participant to reach at least 80 to 85% of their maximal heart rate. And as we'll discuss later, that is going to be a vigorous intensity level.
Another interesting topic in research in Parkinson's disease is exercise and immunomodulation. Research demonstrates that brain-derived neurotrophic factor, BDNF for short, is widely expressed in various parts of the human brain. Research also demonstrates that this molecule is involved in several processes such as enhancing the connections between neurons, promoting the development of immature neurons, and prolonging the survival of mature neurons. In 2014, Zolad et al. Conducted a study to measure inflammation markers in 12 PD patients before and after moderate intensity interval exercise training, which included 3 one-hour training sessions weekly, lasting for 8 weeks. In this study group, BDNF concentrations more than doubled after the exercise intervention. A systematic review of the effect of exercise and BDNF levels in PD shows a trend of increased BDNF levels after exercise, which could be interpreted as exercise helps to enhance neuronal connections and neuronal survival in Parkinson's disease. In the same study, Zolad et al. Also measured pro-inflammatory markers such as soluble vascular cell adhesion molecule 1 and tumor necrosis factor alpha before and after exercise in people with a diagnosis of Parkinson's disease. A balance of these pro-inflammatory markers helps to regulate the body's immune system. Higher levels of these pro-inflammatory markers have been reported to be associated with increased inflammation levels. In this study, after exercise, the levels of these pro-inflammatory markers were slightly lowered. This finding suggests that exercise can help to modulate the immune system and possibly reduce inflammation. Further randomized clinical trials on the effect of exercise on BDNF and pro-inflammatory marker levels are necessary to further validate these optimistic trends of enhanced neuronal connectivity and reduced inflammation.
So, looking specifically at research that was conducted at UBC, Pacific Parkinson's Research Center is involved in many areas of research, including genetics, the microbiome, sleep, novel treatments, and of course, exercise. Our research is ongoing, and we have participants with Parkinson's as well as healthy controls take part in our studies. More information on research being done at PPRC can be found at the end of our presentation in our resource slide. The study we will focus on today was conducted at UBC by Dr. Stossel, a professor and the head of neurology at the Javid Mofaghian Center for Brain Health, and Matt Sigelli, who is a doctoral candidate. So the therapeutic effects of exercise in PD are commonly reported. However, the underlying mechanisms are unknown. Dr. Stossel and Matt Sigelli designed a research study funded by the Pacific Parkinson's Research Institute to investigate brain chemistry changes elicited by exercise in a population of people that didn't exercise with a diagnosis of PD. So some of the brain chemistry that we were looking at included neuroinflammation, the dopamine levels in the brain, as well as the amount of dopamine producing cells in the brain. So we recruited 26 sedentary participants with Parkinson's, and all the participants underwent baseline testing to provide us with a normal that we could then use to compare to our future measurements and calculations. The baseline testing consisted of neurocognitive tests, motor assessments, VO2 max testing, fMRI, and positron emission tomography, also known as PET scanning. And we'll discuss each of these a little bit more in depth in future slides. After completing the baseline testing, approximately half of the participants were enrolled into a 3-month intense aerobic exercise program. The other half of participants were enrolled into a 3-month flexibility and stretching exercise program. So all the participants attended classes 3 times a week and spent an hour at each class. This was done to control for any positive effects seen from social and group interactions. After completing 3 months of either the intense aerobic exercise program or the stretching and flexibility exercise program, all participants repeated that initial testing again to look at changes in brain function and examine the cause of any brain chemistry differences that we saw in people with Parkinson's versus the healthy controls.
So I'm going to talk to you a little bit about positron emission tomography, which can also be called PET for short. It is an imaging procedure in which a radio tracer, which is a radioactive labeling agent, is injected through an intravenous line to investigate neurochemicals and pathology. At UBC, radio tracers are created at Triumph using a cyclotron. A cyclotron is a particle accelerator, and it is used to accelerate particles of carbon and fluorine. These particles begin to collide in the cyclotron, changing their anatomical structure. After the particles have collided for some time in the cyclotron, they become radioactive isotopes known as carbon-11 and fluorine-18. Chemists at Triumph fuse together radioisotopes to a small amount of biomolecules. Biomolecules act on certain cell receptors in the body, and they can be comprised of medication or biological molecules such as glucose. The type of radioactive biomolecule or radiotracer used by researchers depends on which neurochemicals or cell receptors the researchers want to investigate. Once the radiotracer enters the bloodstream of a research participant through an IV, imaging begins using a PET scanning machine. Inside a PET scanning machine, there are thousands of crystals that capture radiation emissions from the body of the research participant. The crystals measure the amount of radiation emissions at the binding sites of the radiotracer, creating an anatomical map or picture of radiotracer uptake. So one of the scans that all of the participants in the exercise study at UBC completed is a PBR scan, and this scan allows researchers to look at inflammation. The reason that we decided to look at inflammation is because we wanted to understand if aerobic exercise causes changes to neuroinflammation levels. The picture on this slide shows PBR radiotracer uptake. Areas of red indicate parts of the brain where the PBR tracing binding was high, and areas of blue and green indicate areas of the brain where the PBR tracer binding was low. In the exercise study at UBC, all participants underwent a rack PET scan to measure dopamine levels in the brain. They then completed a session of transcranial magnetic stimulation. Transcranial magnetic stimulation, TMS for short, is a non-invasive procedure that uses a magnetic pulse to stimulate areas of the brain. TMS stimulation causes the brain's dopamine-producing cells to produce dopamine. After completing a session of TMS, the participants completed another raclopride scan to look at change in dopamine levels elicited from the TMS. This series of procedures was conducted in all exercise participants before and after 3 months of exercise. The study aim was to determine if aerobic exercise causes an increase in dopamine release. All participants in the exercise study at UBC also completed TBZ PET scanning before 3 months of exercise to establish a baseline level of dopamine-producing cells in the brain. TBZ allows us to measure the amount of dopamine-producing cells. Participants will be invited to come back in 3 years' time to repeat the TBZ PET scan to look at changes in levels of dopamine-producing cells. The study aim is to determine if aerobic exercise preserves dopamine-producing cells. And can exercise also help to delay the progression of Parkinson's disease?
So all participants underwent VO2 max testing before and after their 3 months of either aerobic or the stretching exercises. In the VO2 max test, what participants wear is a breathing mask that records their oxygen consumption while they undergo a progressively more challenging stationary cycling test. It measures exercise endurance capacity and cardio fitness by calculating the maximum amount of oxygen a person can breathe in and utilize during that intense exercise. The VO2 max testing was completed to ensure that the aerobic group did in fact see an improvement in their fitness levels compared to the stretching group. All participants also underwent an fMRI scan before and after those 3 months of respective exercises. fMRI is an imaging technique, and it uses a magnetic field to measure the brain activity by detecting changes in the blood flow. So we performed a gambling-based task with the participant while they were in the fMRI, and this was done because the response to reward is different between those with Parkinson's and healthy people. So we wanted to determine if routine aerobic exercise helped to normalize the reward motivation response in the brain.
So many movement disorder neurologists that practice at the Center for Brain Health in Vancouver are now including a recommendation for exercise in their patient care plans. Exercise in the general population has been reported to elevate mood and well-being, support the immune system, increase GI motility, enhance cognition, help with sleep, and amongst many other things. An emerging area of research is to determine whether these exercise benefits also hold true for people with a diagnosis of Parkinson's disease. If these benefits carry over to a population with Parkinson's disease, then exercise may be a favorable treatment option for some of the non-motor symptoms of Parkinson's disease. So far, the small amount of research on exercise and non-motor symptoms of Parkinson's disease has shown promising results that may possibly support prescribing exercise to not only treat motor symptoms, but also treat the non-motor symptoms of PD. Prior to engaging in exercise, it is important to determine if it is safe to do so. Consulting a health professional is recommended, especially if you have a condition like Parkinson's disease which impacts mobility. An assessment form called the Get Active Questionnaire can help you to identify whether it is safe for you to exercise. You can complete this form with your family physician, a physiotherapist, or a qualified health professional. After the qualified health professional obtains a detailed understanding of any health challenges, they can recommend what types of exercise will be the most beneficial for you based on your exercise capacity and specific health limitations. We have included a link to the Get Active questionnaire on our resource page at the end of this webinar.
CSEP, which is the Canadian Society for Exercise Physiology, has created physical activity guidelines, and these guidelines were created based on systematic reviews of the best available evidence. The recommended amount and intensity of the exercise recommended is sufficient to obtain substantial health benefits. As Parkinson's is age-related, with more than 95% of those with PD over the age of 60, we'll take a look at the guidelines for older adults. So the current recommendation is to try to achieve 150 minutes of moderate to vigorous exercise per week, and I'll talk about what moderate to vigorous exercise means in the next couple slides. And where possible, the guidelines recommend adding weight training and resistive exercises, so that helps you maintain muscle and bone strength. These exercises can be imperative, as research has also supported, to reduce fall rates. And of course, more exercise will result in more health benefits. So talking about what exercise intensity means, it's important to note that exercise intensity is quite individualized. A workout routine might feel easy and light to a habitual exerciser, but it may cause someone who's been largely sedentary to reach a vigorous level. A good way to determine your exercise intensity is to pay attention to your levels of perspiration and your ease of breath or conversation. Light exercise should not cause you to break a sweat, and you should be able to maintain a conversation without any difficulty. Moderate exercise typically includes activities that cause some light sweating and faster, deeper breathing. And finally, vigorous exercise results from activities that cause heavy sweating as well as feeling out of breath with an inability to carry on any conversation. Moderate to vigorous exercise is achieved through aerobic activities. Aerobic exercise, which is also known as cardio, means with oxygen, and that refers to the use of oxygen in the muscle's energy generating process. Aerobic exercise is really anything that gets your heart pumping. So examples could include brisk walking, jogging, cycling, dancing, or swimming.
So Michelle McCarthy is an experienced physiotherapist specializing in movement disorders at the Center for Brain Health at UBC. We are pleased to share with you some tips from Michelle on how to stay active with Parkinson's disease. Choose an activity that you enjoy. This way, you will be more likely to stick to it. Exercise with a friend or partner. They will motivate you, keep you on track, and increase your feelings of safety while exercising. Consider exercising at the best time of day for you. If you feel best when you are on your Parkinson's medications, then this may be an ideal time to exercise. Set realistic goals. This way you will be more likely to achieve them. Try to incorporate exercises into your daily activities so they become routine. Practice a balance of different types of exercise. Consider if you prefer group or individual exercise.
In order to have the best chance of accomplishing your goals, it's important to make sure they're achievable and livable so that you stick to your behavioral change. If your goals are too challenging, you're not going to be able to make any progress and you'll probably give up altogether. The SMART criteria is an excellent guideline to follow when setting goals to give yourself the best shot at success. So it stands for specific, measurable, attainable or achievable, realistic, and time frame specific. We'll go through each one to explain it a little bit and provide examples of how it might apply to your exercise goal. So be specific. Try to avoid vague goals where possible. Instead of only saying, I want to exercise more, try to state more specific terms like, I want to exercise for 30 minutes at least 3 times a week. Make your goals measurable. It's much easier and more rewarding to track your progress if your goals are quantifiable. So measuring your goal can be done in a time, such as walking for 20 minutes, or it could be done in distance, such as swimming a kilometer. Make attainable goals. Set goals that are within your physical limits. If you have gait difficulties or feel like you're at a risk for falls, it doesn't make sense to set a goal of running for 5 miles a day. It's more prudent to exercise in a pool or an aquatic setting. Be realistic. Manage your expectations when you set your goals. It's hard to start exercising for hours a day if you haven't been very active lately. Start small, like trying to walk around the neighborhood with a friend before increasing your intensity. And finally, try to make your goal time frame specific. Give yourself a reasonable amount of time to reach your goal. Make sure that you have time designated in your week to fulfill your goals, and decide how much time you want to give yourself to accomplish your goal. It's important to make time for exercise in your week. Here are some ideas for incorporating more physical activity into your day. These ideas might not be applicable for all those with PD depending on the severity of your disease and mobility restrictions. Please take into consideration the recommendations of your healthcare provider. To start, you could try doing errands by foot. If you can, leave your car at home and walk to the store to see a friend. Take the dog for a walk. If you don't have a dog, you could borrow your family, friend, or neighbor's dog. Sweeping the walkway, you can try interval sweeping where you pick a 10-meter strip of cement and then sweep as hard and as fast as you can. Doing calisthenics in the morning. So calisthenics are resistive exercises that use your body weight as the resistance. And it's good for some people who might like to develop muscle strength but aren't willing to join a gym or a health club. And you could try doing push-ups, squats, curl-ups, crunches, or chair dips in your home. And lastly, exercise and housework. A vacuum cleaner could be a lunch machine. You can try wearing a weighted vest or a backpack while you dust. You can stretch while folding laundry. With a little creativity, you can turn simple household chores into a weight and aerobics workout. Warm-ups are important because the body's muscles work better when their temperature is slightly above their resting level, and warming up enhances performance and decreases your chance of injury. It gives the body time to redirect blood to active muscles, and it gives the heart time to adapt to its new demands. Warm-up sessions should include low-intensity, whole-body movements similar to those in the activity that will follow. For example, if you're doing a walking test or a walking task, you could walk at half speed before progressing into a more brisk walk. And an active warm-up of 5 to 10 minutes is usually enough for most exercise activities. However, it does depend on your level of fitness, experience, and just preference. Cool downs are important for returning the body to its resting state. A cool down can help maintain blood flow to the heart and brain, and it redirects blood from working muscles to other areas of the body. A cool down would help prevent complications such as dizziness or a large drop in your blood pressure following exercise. A cool down consisting of 5 to 10 minutes of reduced activity should follow every workout to allow your heart rate, breathing, and circulation to return to normal. For an example, if you're doing a cardio workout, you could begin your cool down by moving at half speed for about 30 seconds to a minute and continuing to reduce your exertion levels before stopping exercise completely. So there are many health benefits of exercise. Generally, it's important to maintain overall health because it makes the heart stronger, it decreases your blood pressure, and it improves blood supply to your tissues. But exercise has also been shown to dramatically improve non-motor symptoms, such as mild to moderate depression, anxiety, and your poor sleep quality. The reasons behind these results are not fully clear, but hypotheses are drawn from exercise impacting dopamine and serotonin levels, or brain-derived neurotrophic factor, which Nicole discussed earlier. These physiological benefits allow you to stay more independent with age, and it prevents your risk of falls as well as providing cognitive benefits. Here are some inspirational thoughts from Participation, and they just show the benefits of exercise in the general population. We've also left the website as a resource at the end of our slides if you would like some extra motivation for getting active. One exercise that's popular that's done to see the benefits is Tai Chi. Tai Chi is an internal Chinese martial art, and it's practiced for both its defense training but also its health benefits. Tai Chi is often described as meditation in motion, but it's also been called medication in motion. It's a low-impact, slow-motion exercise that integrates balance, flexibility, and coordination training, as well as cognitive components. It's been well supported to improve a wide range of motor symptoms as well as non-motor symptoms. In a study in 2012, 24 weeks of Tai Chi training resulted in a decrease of monthly fall rates by 11 to 26% over a 9-month period in comparison to resistance and stretching controls. Another popular and increasingly well-known sport that people with Parkinson's have adopted is boxing. Boxing movements incorporate motions to do with your spinal flexibility, stepping in multiple directions, and movements performed at high speeds. This physical training, combined with the benefit of social interaction, help with posture, muscle strength, and increased quality of life. A 2011 case study following 6 participants with PD specifically showed improvements in walking, balance, and performance of daily activities.
In order to promote exercise and an active lifestyle, it is important to understand barriers to exercise. A study in people living in the community with Parkinson's disease identified 3 barriers to be the most important factors to limit exercise participation in Parkinson's disease. These barriers are low outcome expectation, which is a perception that exercise has no benefit. Lack of time to exercise, which is a perception of not having enough time to partake in exercise activities. The researchers in this study also further clarified that this barrier may reflect difficulty prioritizing and planning daily activities due to cognitive changes seen in some people with Parkinson's disease. The third barrier is fear of falling, which is fear or worry of falling during upright or ambulatory activities or exercise. Fear of falling is associated with activity restriction in older adults who are healthy and also those with Parkinson's disease. Fear of falling has also been described as an independent risk factor for falls in people with Parkinson's disease. This means that if you have a fear of falling, you are more likely to fall. Now that we understand what the barriers to exercise in Parkinson's disease are, let's talk about ways we can overcome them. First, we will discuss ways to overcome the barrier of low outcome expectation from exercise. To address this barrier, you can attend educational sessions on exercise to further your knowledge on how exercise can benefit you. This webinar is a great step in the right direction. You can also set goals for yourself. This will allow you to review your progress and appreciate your achievements. Remember the SMART goals slide. Asking for feedback on your progress can also help you to receive positive reinforcement and encouragement from others. Others may also notice benefits that you are experiencing as a result of exercise that you are unaware of. Relapse prevention training involves cognitive behavioral therapy and can help you to restructure negative thoughts about exercising. Finally, self-reflection and journaling your exercise progress can help you to identify patterns and positive changes in your health and well-being. Think of journaling as a self-study. Look for and document changes in how you feel after you exercise. Over time, look for patterns and themes in your day-to-day journal notes. The second barrier we discussed is lack of time to exercise. To overcome this barrier, you can prioritize exercise in your life, schedule exercise into your routine, this way it becomes a habit, ask for assistance from family and friends with scheduling exercise, ask family and friends to reinforce exercise activities by inviting them to join you in exercise participation, and also asking them to help keep you on track. The final barrier to exercise that we discussed is fear of falling. Ideas to overcome this barrier include asking your healthcare provider for a realistic self-assessment on the risk of falling, making sure that the environment you are practicing exercise in is safe, seeking assistance in situations where you experience fear of falling. Practicing weight-bearing exercises can help to maintain bone health. You can also ask your family doctor for a bone density check and ask if they recommend calcium and vitamin D supplementation to assist you in maintaining healthy bones. The use of walking aids such as a cane, hiking poles, or a walker can assist you with upright movements. Completing exercise while you're seated or lying down will also help prevent falls. Participating in supervised water fitness classes in waist-depth water will lessen the chances of falling as the buoyancy of the water will help to hold you up. In a water fitness class, you can also ask to use flotation devices.
So that's pretty much our presentation today, and just to wrap up and consolidate some of the information that we've shared with you today, because we know it's a lot, we'd like to go through some of our learning outcomes now. We started with describing PD symptoms, and then we covered pathophysiology, with the most important point being that motor dysfunction in PD is seen due to dopamine deficiency. Currently, Sinemet, or levodopa, is given as treatment, but it does have its limitations. And in terms of prevalence of PD, it's found in 1% of adults over the age of 60. Exercise has arisen as a possible treatment option, not to cure PD, but to slow the progression of the disease. Aquatic therapy, treadmill training, boxing, which are some examples of aerobic exercise, as well as Tai Chi, have shown positive impacts on motor and non-motor symptoms. Exercise has also been shown to reduce neuroinflammation in those with PD. We hope that you've learned more about research at UBC and how we are advancing knowledge in an effort to treat and delay the progression of Parkinson's. The exercise study at UBC will hopefully help to uncover that aerobic exercise induced neurochemical changes in the brain and will help further this vision. Takeaway that CSEP recommends 150 minutes of moderate to vigorous exercise a week, incorporating muscle and bone strengthening exercises 2 days per week, performing activities to enhance balance and prevent falls, and that more physical activity results in greater health benefits. And finally, as we just discussed, the most important barriers to exercise for people with PD include low outcome expectation, lack of time, and fear of falling. We also shared with you some resources and knowledge to overcome these barriers to exercise.
This slide concludes our webinar. Thank you to everyone for investing your time today to view the webinar. We would also like to thank all research participants, because without them, advancing knowledge in Parkinson's disease would not be possible. Thank you also to the Parkinson Society of BC for hosting this webinar, and thank you to all of our colleagues who assisted us in creating this webinar. These are just some of the references used throughout the presentation. Again, more references. This is just a reference slide for the pictures, some of the pictures used in the presentation.
And then, as mentioned throughout our presentation, here's the resource page that contains some relevant and informative links talking about research, exercise, and Parkinson's disease. So that concludes it, but I think now we'll take a look at some of the questions to see if we can offer any clarification for some things you guys might